Hi guys, in this video we're going to talk about the anatomy of the small intestine. So the small intestine consists of three parts: the duodenum, the jejunum, and ileum. So the duodenum lies at the level of L1 to L3 and in the epigastric and umbilical region. Now to talk about the locations of the jejunum and ileum, we're going to talk about that as we proceed and reach them. Now let's talk about the duodenum. Now, the duodenum is the first part of the small intestine. It's the first part to receive the chyme from the stomach, and it has an important relations. Now, the first part of duodenum is related superiorly to the hepatoduodenal ligament. Remember, you guys, when we talked about the peritoneal ligaments, and we said that the lesser curvature of the stomach is related to the lesser omentum, and it attaches the lesser curvature to the liver, and it has two parts: part that is related to the stomach and part that is related to the duodenum, because we usually consider the first inch or first part of duodenum as everything of it is very similar to the stomach. So the first inch of the first part of duodenum is attached to the liver by part of the lesser omentum, which is the hepatoduodenal ligament. All right, it's the ligament that is between the liver and the duodenum. Now, why the hepatoduodenal ligament is important? Because remember, you guys, when we talked about in the peritoneum concept in the previous video, we said that the only opening or the only communication between the greater sac, which is the space in front of the stomach in your abdominal cavity, and the lesser sac, which is the space behind the stomach, is the epibloic foramen. This information is very important during surgeries. For example, if there is liver bleeding, we know that if I put my finger in the epibloic foramen, what's in front of me is the hepatoduodenal ligament, and what runs in that is the portal triad, which is basically the hepatic artery, the portal vein, and the bile duct. Now, these two concern me because this is the blood supply to the liver. So during that, if a surgeon found any bleeding in the liver and there is a problem with the liver, so he will put his finger in that, he will squeeze that part, and then he clumps it, all right, to stop the bleeding of the liver. So if you guys look at this, this is exactly what runs in the hepatoduodenal ligament. It's basically, if I have an artery, that's going to be the hepatic artery, and then I have the bile duct, and posteriorly I have the portal vein. So what I'm basically doing when I squeeze that part, I'm squeezing the blood supply to the liver. So in that, I can stop the bleeding during surgery. So it's very important to know the superior relation of the first part of duodenum. Now, what about the anterior and posterior relation? Now, when we talk about the first part of duodenum, all right, it's important to know that it's anteriorly related to the liver and gallbladder, and posteriorly it's related to the common bile duct, portal vein, and gastroduodenal artery. Now, we said that superiorly it's related to the portal triad. So posteriorly, it's the same structures, but instead of the hepatic artery, all right, I have a branch of the common hepatic artery, all right, which is the gastroduodenal, because at that point, posteriorly, I don't have the common hepatic. I have something that's going to the duodenum, which is basically my gastroduodenal artery. So can you guys see that? So if this is my celiac trunk and this is the splenic, I have the left gastric, I have to the right side the common hepatic. At the upper portion here, superiorly in the gastroduodenal ligament, I have the proper hepatic. This is the common bile duct and the portal vein at the back. So these are the portal triad. However, below down, posterior to the first inch, this is the duodenum, but the first inch was basically here. So posterior to that, I have the same structures, but instead of the proper hepatic, I have the gastroduodenal, and that is very important. All right, we're gonna say in a while why. Why is it important to know that the gastroduodenal is related posteriorly to the first inch of first part of duodenum? Because the first inch of first part of duodenum is very acidic and it's very vulnerable to peptic ulcer. So if I get to have peptic ulcer, that can cause erosions in the wall and perforations of the wall of the duodenum. And if that happens, we need to know that the gastroduodenal artery is lying posterior to the first inch of first part of duodenum, which is very vulnerable to the peptic ulcer, and that can cause destruction to the wall of the gastroduodenal artery, and that can end up having bleeding, and that can cause hematemesis. All right, hematemesis, which means vomiting of blood. So if you get to see a patient with these signs and symptoms, other than other signs and symptoms, you would expect that there could be a problem, plus epigastric pain and other features. You would expect that this patient is having, he could be having peptic ulcer. So this is very important to know. This is the posterior relation of the first part of the duodenum. All right. Now, what about the second part? Second part, we've talked about that in the extra hepatic biliary passage. It's all related to the extra hepatic biliary passage. The second part, of course, you guys know that the C-shaped duodenal is wrapping around the head of pancreas. So the head of pancreas actually is inferior relation to the first part, is medial relation to second part, is superior relation to the third part, all right? And lateral relation to the fourth part. So it's basically related to all parts of duodenum, but that doesn't concern me now. What concerns me is this: in the second part, the most important relation is the opening of the common bile duct. All right, when it unites with the pancreatic duct to form the ampulla of Varer, and the ampulla is actually a union of the common bile duct. Remember how the common bile duct is formed? If you guys need to revise that, you can go back to that video and listen to more explanation about the biliary system. So, but at that point, I have the ampulla, and that ampulla, I call it, as it's a union of stuff coming from the liver and stuff coming from the pancreas. So I'm gonna call it the hepatopancreatic ampulla. It's basically the widening within the wall of the duodenum, and that opens into a papilla. Papilla means an elevation in the wall of the duodenum itself, and this is the major one because it's the most important one, and because it's an opening in the duodenum, so I call it major duodenal papilla. However, there is another one, which is the accessory pancreatic duct, where the accessory pancreatic duct opens. All right, so if I look at this diagram, this is the major one. I have the minor one, it opens above, it's a minor one. I don't have that in the diagram, and that opens into a smaller papilla. All right, and that is what I call the minor duodenal papilla. Okay, so these are the important relations to the second part of duodenum. Now, the third part of duodenum is related to many structures, but the most important thing is that I have two vessels anteriorly, and two vessels posteriorly. If you guys look at the posterior ones, it's basically your aorta and the inferior vena cava. And the two anterior ones are the superior mesenteric vessels. So you have the SMA and SMV, the superior mesenteric artery and superior mesenteric vein. If you guys look at this, this is the superior mesenteric artery and this is the superior mesenteric vein. All right, and these are very important relations to the third part. Why? Because let's look at the clinical notes. What happens is we can get a syndrome that's called the SMA syndrome, and that syndrome can, let's look at this picture here to understand more about the SMA syndrome. If you guys look at the superior mesenteric artery, all right, if you guys look at this artery and you look at the aorta, which is basically here, the black colored aorta is at the back, you guys can see that there is an acute angle between them that can cause squeeze or compression on the third part of duodenum. If you guys look at the third part of duodenum, you can see that the superior mesenteric is having a very acute angle with the aorta. And if that happens, that can cause compression on the third part, and that can end up having nausea, vomiting, and gastrointestinal problems. All right. So the reason is because the superior mesenteric artery is anteriorly related to the third part, and it can compress the third part of the duodenum. The same idea we have it's because of the acute angle. Can you guys see the left renal vein? All right, so the left renal vein also can be compressed because of the acute angle, again, between the superior mesenteric and the aorta. All right, and that's what we call the nutcracker syndrome. And if that happens, and if we compress the left renal vein, that can cause flank pain and blood in urine. So that's why it's very important to know that the third part of the duodenum is related anteriorly to two important vessels, SMA and SMV, and posteriorly it's related to the inferior vena cava and the aorta to the left. All right. Now, what about the fourth part? The fourth part is a simple part. It's basically the part that you guys can see here, the ascending part, from this point till this point, and it's related to anteriorly to the transverse colon and mesocolon. It's related posteriorly to the psoas major and left gonadal vessels, testicular or ovarian, and then it's important to what's important to know at that point is the duodenal jejunal junction. All right, that is basically fixed with the ligament of Treitz or Treitz. This ligament is formed by muscle fibers coming from the right crus of diaphragm. If you guys look at the right crus of diaphragm, you can see that we have the slings of the muscle fibers coming all the way to the duodenal junction. And that is important because this junction is usually closed if we don't need to pass any chyme in that. However, when it contracts, it straightens the junction to allow the food to get from the duodenum to the jejunum. All right. So that's the clinical importance. It's not clinical importance. This is the physiological importance of the ligament of Treitz. Now let's recap. So when we talk about the duodenum, remember that in the first part, anteriorly, it's related to liver. So it's related to the liver and the gallbladder. Posteriorly, it's related to the portal triad. And instead of, guys, remember that the portal triad is basically your hepatic artery, your common bile duct, and the portal vein posteriorly. Now, instead of the hepatic artery, it's the gastroduodenal artery, all right? So anteriorly related to the liver, posteriorly portal triad, but the gastroduodenal, and instead of that, superiorly it's related to the portal triad, and it's related to the hepatoduodenal ligament. And we talked about that in details. Now, the second part is it's all about the biliary system. Remember the major duodenal papilla and the minor, all right, and the head of pancreas, all right. And then the third part is related to the two vessels anteriorly and two posteriorly, the SMA and SMV, and posteriorly it's related to the aorta and inferior vena cava. And then the fourth part is related to the transverse colon and mesocolon, and posteriorly related to the psoas major and gonadal vessels, all right, left gonadal. Now, to know the blood supply of duodenum, you will find it in the anatomy of extrahepatic biliary system video because it shares the same blood supply of the head of pancreas. Now, moving on to the jejunum. The jejunum is located in the left upper quadrant. So mainly we can see the jejunum in the left upper quadrant. However, the ileum is located in the right lower quadrant. All right. So these are coils of jejunum, and these are coils of ileum. All right. Now, what about the peritoneal ligaments? So to talk about the peritoneal ligaments, the small intestine, as you guys can see, that's the whole small intestine it's actually an intraperitoneal structure. It succeeds to get into the peritoneum and it gets suspended by the proper mesentery. and that attaches the small intestine in the posterior abdominal wall. And we talked about how does that form in the peritoneal concept video. You guys can watch that to get more information about the mesentery proper. All right. And now the blood supply is basically coming from the superior mesenteric artery. So in the aorta, we have the celiac trunk, we have the superior mesenteric artery and an inferior mesenteric artery. The celiac is the artery of foregut, and we've talked about that in the foregut structures. The SMA is the artery of midgut, and we talked about that in the duodenum. And to continue the story of the SMA, because the small intestine is part of it, so we have the jejunal. If you guys look at all of these structures here, these are all jejunal branches, and here I have ileal branches. All right, so they are all coming from the SMA. Plus, so I have jejunal, I have ileal, all right, and I have what I call ileocolic. The ileocolic, it has ileal branch that supplies the ileum, and then the colic one, we're going to talk about that in the large intestine. Now, there is very important comparison between the jejunum and the ileal branches, because as they run in the mesentery, of course, here this is dissected cadaveric photos, all right, so that I can show you guys the arcades. I just want you to understand the idea of these branches before we proceed with the comparison. What happens is, as the jejunal and ileal branches come in the mesentery to reach the walls, I have jejunal, I have ileal branches. Each one of the branch anastomose with the next, each one anastomose with the next, and then they give more branches, and then they anastomose together, and then they would form arcades. And these arcades together, they will send straight arteries, and the name straight means recta in Latin, and vasa means blood vessel. So they will send vasa recta to the walls of the jejunum and the ileum. All right, so in this, we need to understand the differences between the arcades, the vasa recta, the branches, the walls of jejunum and ileum, the lumen, the vascularity. We have differences between them. So let's take a look and see how we can remember the differences between both of them. Now let's suppose that there is a story. There is a story between the jejunum and ileum, and that story is basically J is for jejunum, and I is for ileum. So J, jejunum, it's for Jasmine, and I for Ilyas. So the girls like to be dominating, and they like to get everything more than boys. All right. So if we think about comparison, remember that everything is more for Jasmine. Jasmine is jejunum, and ileum is Ilyas. All right. So what happens is the wall of jejunum is thicker than the wall of ileum. The lumen is wider. The vasa recta is longer. The color is deeper red. The vascularity is greater, and the plica circularis is larger and taller. That you can see it in the histological sections. You cannot see it in a gross feature. All right, but this is a good way to remember the differences later on, even in written exams. Now, thinking about the Ilyas, he has, sorry, this is thinner. All right, so the wall is thin, the lumen is narrow, the vasa recta is shorter, the color is pale pink, everything is less, vascularity is less, plica circularis is low. So everything is more with Jasmine, except, okay, I'm sorry. Everything is more except the intestinal arcades. Think about the arcades as the skin creases. So this is something bad. So Jasmine wouldn't like it. So of course she will give it to Ilyas, all right, because she's dominating. And the fat is in mesentery is something that we don't like as girls. So of course she will give it to Ilyas. So he is winning to have more fat in mesentery. And the last thing is the Peyer's patches. This is, of course, the lymphoid nodules in the submucosa, and this is something you guys cannot see in gross features that you can see in histological sections, okay? And this is the only thing that you need to memorize. So everything is more for jejunum except the intestinal arcades and the fat and mesentery, which is something that's not nice. If you look at the picture, you guys can see that longer vasa recta, the wall is thicker, all right? But the arcades are fewer. If you guys can see the arcades, they are fewer. But here we have a lot of arcades. Okay, so this is the only thing that it would Elias would be able to take. And of course, we cannot see the fat and mesentery in this picture because it's already dissected away. So we don't have here. We can see the fat here in the ileum. It's more here. It's not dissected. All right, and we cannot see the vascularity here because this is a cadaver. It's more can be seen in a real human. All right, and here the wall is very thin. All right, so this is the way you guys can remember the differences between the jejunum and ileum. With that, we're done with the anatomy of the small intestine. I hope you guys enjoyed it. I hope you can remember everything in the comparison between jejunum and ileum. Thanks for watching. Don't forget to like and subscribe, and see you in the next video.